Morning, and thank you everyone for joining us for our webinar. This is the third in a four-part social prescribing series, and this one focuses more on primary care related perspectives on social prescribing. And so we're really excited to have you all here to join us today for this webinar. Before we begin the webinar, I'd like to do a land acknowledgement. United Way acknowledges the homelands of the Indigenous peoples of this place we now call Canada and honor the many territorial keepers of the lands on which we work. I personally am working from home today, so I'm calling in from the traditional, ancestral, and unceded territories of the Coquitlam First Nation. And I would welcome you, if you know the territories that you're joining from, to put that in the chat box as well as introduce yourself. A few housekeeping notes before we start the presentations. So during the webinar, the audience will remain muted, but feel free to introduce yourself in the chat box if you'd like. You also can turn on the automatic closed captioning feature, and it says CC at the bottom of the toolbar if you'd like to use that feature. There will be a brief question period at the end of the session. Feel free to put questions that you might have in the Q&A box or in the chat. And the webinar is being recorded and will be posted on Healthy Aging Core, and will also make the presentation slides available. And so now I'm going to pass it over to our moderator for the webinar, and that is Dr. Kiffer Card. And so he'll introduce the webinar series and the webinar.
Thanks, Laura, and it's a pleasure to be with you. Thank you for all your hard work and kind of convening and bringing together this webinar series, and this webinar in particular, which is a collaboration between the United Way BC and the Canadian Alliance for Social Connection and Health as part of a multi-part webinar series focusing on the role of social prescribing and diving into unique perspectives such as what we're covering today. I'll introduce today's webinar topic briefly and each of our guests, but also just wanted to call attention that there is a future webinar as well, Social Prescribing in British Columbia, in which we'll cover research insights on the program implementation and volunteer contributions, and that'll be on June 26th at 10 a.m. So if you enjoy today's webinar presentation, don't miss out our next one, because this has been a really great series so far. So today we've got really great guests who are talking to us about the clinical side of social prescribing. Of course, those of you familiar with social prescribing, there are many different ways to implement it and have it in our communities. Some of them are more community-led. But I think one of the brilliant things about social prescribing is it emphasizes the role that everyone across all layers of society plays in creating health and wellness in our individuals and in communities. So in diving into the relationships between doctors and patients and patients and patients and doctors, this webinar series will really help us to understand how we can best utilize and design the various pathways that make up social prescribing. And of course, a common thread in all of this is that social connection and relationships aren't just peripheral concerns, but they're core to how we engage in medical practice, in healthcare systems, and public health. And therefore, it's important that at this time and through social prescribing efforts, we engage in these meaningful conversations to help people understand the importance and to have examples of how this can be done in new and innovative ways that really enhances the health and well-being of our communities and patients and clients and all those who we work with. So our first presenter today will be Daniel Gan, and he's a health policy analyst and adjunct professor in the Faculty of Health Sciences at Simon Fraser University, which is also the faculty that I'm affiliated with. And in working with Daniel, it's a pleasure. He has a strong background in health sciences research and data analytics and digital approaches to social prescribing. Today, he's going to be sharing insights into how we can harness technology and evidence to build effective, scalable social prescribing models that meet the needs of older adults. And complementing Daniel's presentation will be presentations by kind of a co-presentation by Dr. Adam Hoverman and Gloria Harding. Adam is a family medicine physician at the Wellington Medical Clinic in Nanaimo and a clinical instructor at both the University of Washington School of Public Health and UBC's Faculty of Medicine. I've known Adam for a number of years now, as we've engaged on a wide variety of research projects to date. And Adam, I can tell you, brings really a global and community-informed lens to his work, grounded in the experiences. He'll share information about novel models of social prescribing, including what's termed group medical visits, and how these can serve as an innovative model that really builds on the core foundations and principles of social prescribing. So very excited to hear about that. And as I mentioned, joining Adam will be Gloria Harding, who's the Indigenous Relations Manager in the Nanaimo Division of Family Practice. Gloria joined the division in 2022 and collaborates with Indigenous partners to integrate principles of cultural safety and humility within the Nanaimo division and the Nanaimo Primary Care Network. And she is a Métis citizen affiliated with the Métis Nation of British Columbia, and her heritage belongs to the Red River settlement in Manitoba. Gloria combines her personal experience with her formal education in these efforts, drawing upon the teachings imparted by her families regarding Métis culture. And she values spending time with family, engaging in beading, cooking, and volunteering at Indigenous community events. Her culture remains a vital source of inner peace and strength. And so I think we're really lucky to have her sharing her perspectives on social prescribing and clinical care settings as well, combining that wealth of knowledge that we all value. After the talks, we'll have a Q&A. We'll start with a few questions that we've kind of developed, but then we'll open that up. So feel free to use the chat or the Q&A function to add questions that you might have that come to the forefront of the conversation at this time. And with that, thank you to all of you for attending. And thank you to our speakers. I'll pass the time to Daniel.
Hi, everyone. Thank you so much, Dr. Kivakar, for the warm welcome and presentation introductions. So today I'm talking about the social prescribing theory of change. This is a science-backed one, from social emotional loneliness to well-being through comfort with primary care and community care discussions and openness to social prescribing. Next slide, please. I'm joining you today as part of the Healthy Ecologies and Lifestyle Lab. And previously, I've also have experience working with Indigenous-led organizations on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. I gratefully acknowledge joining you today from the traditional unceded territories of the Quilculum First Nation. Next slide, please. So this is one of the things that came out from discussing with older adults over the over 12 focus groups several years back, and you can see this comprehensive model. Some of you might be familiar with it. This is some of the work that came out from that deep engagement with community perspectives. So I'm grateful and thankful to have community connectors like yourself and also decision makers in the community today. And a lot of this, what we study and learn today, and what I'm sharing today, comes from your knowledge and your perspective. And so I just really want to acknowledge that. Next slide, please. So, and recently I also have the opportunity to work with our co-presenter today, Dr. Adam Hoverman, on this digital social prescribing model. And again, this is an idea that came from the community, and then we went out to find out like the landscape of all the challenges and maybe some of the things that you see in there, staff burnout, sectors with different mandates. Maybe some of those will resonate with what you're experiencing, and hopefully as research progresses, we can find more solutions with you, for you, and also with all our input together. Next slide, please. So what I'm going to do today is really to share further analysis from a survey that we did in 2022. We're here referring to the Healthy Ecologies and Lifestyles Lab, led by Dr. Kiefer. There we had more than 4,000 Canadians above 55 answering to a survey questions. It's a cross-sectional one. And then what we collated all the questions that we asked and the general numbers in 2023 in this document here, Social Prescribing Needs of Older Adults in Canada. And today we are going to gather your input for further further analysis that have been conducted in the lab and explore how social prescribing might help people evolve from loneliness to well-being. Because what we want to do is want to kind of break down the process of change, right? How does one move from loneliness to well-being? So if we think about all the older adults that we interact with, or the patient partners that we interact with on a daily basis, if we were to categorize them into two groups, what might that two groups be? And so what our webinar today is offering a perspective on that. And also, hopefully, we get to discuss more clinical and programmatic implications with yourself and also with Dr. Adam Holman in the next 15 minutes or so. Next slide, please. So, okay, so some of the questions that we asked are shown, that we're going to analyze today, are shown on this chart. So on the left-hand side, we have social loneliness and emotional loneliness, and they are measured with different items. Like, for example, social loneliness is measured with people I can rely on, many people I can trust, people I feel close to. Emotional loneliness is kind of deeper. It's like, do you experience a sense of emptiness? Do you often feel rejected? Do you miss having people around? So I guess we can tell a little bit of the difference between social loneliness and emotional loneliness, and based on these questions that we've asked. And on the right-hand side, we have well-being that was measured with anxiety, depressive symptoms, and also self-rated health. And in the middle, we have 4 variables here: comfort with primary care discussions on social wellness, comfort with primary care discussions on mental wellness, physical wellness, and general wellness. And so those are some examples are provided in there. For example, social wellness would be referrals to participate or volunteer in community organization, which many of you, I believe, are working in. Comfort with primary care discussions on mental wellness are the respondents comfortable receiving advice on mental health or social connection or fun activities in their primary or community care settings. For physical wellness, you can see there is referrals to physical trainer, nutritionist, or physiotherapists. And comfort with discussions on general wellness would be about physical activity, diet, and substance use. So we have, before I proceed further, before we review the results with arrows and numbers and whatnot, I just want to give everybody the chance to guess. So this is like a trivia, and Wings is going to pop in 2 questions on the screen, and you can answer your best guess. Which of these 4 connects loneliness to well-being? That's question 1. And question 2, which of these 3 connects, again, loneliness to well-being? So just take some time to take a look at the question and give your best guess. The questions are the same, the options are different. There is a correct answer in this case, and we will review it slowly, but soon. But don't worry, your responses are not tracked, so we won't know which one you voted. It's just to keep the webinar interactive. Right, and when everybody has voted, I guess Wingsu will be able to show us the poll results. And all right, yeah, Your answers are correct. So 43% of you said that comfort discussing social wellness helps somebody move from loneliness to well-being, and that's certainly correct. Mental wellness and general wellness as well. We do see a little bit of that, but that didn't come out so strongly in the final connection to well-being. In the second question, this one's a little bit more split. Which of these helps someone move from loneliness to well-being? Beliefs about effectiveness of social prescribing, we got 27%. Expressing support for social prescribing, we have 30%. And beliefs about the meaningfulness of social prescribing is 43%. And I will review the answer very shortly. This is a little bit different. A big proportion of you got it right. But yeah, it's the answer is not beliefs about the meaningfulness of social prescribing, surprisingly. So next slide, please. So what we did is we ran through, we crunched the just previous slide. We crushed the numbers with all the survey results from 1,000 over respondents, and based on their responses, and this process called structural equation modeling, which is a form of path analysis, we can show that there is a relationship between social loneliness and comfort with primary care discussions on social wellness. So people, if they experience social loneliness and if they feel more comfortable with primary care discussion on social wellness, then this is associated with increased well-being. So your guess is correct. The next slide, please. And here, the second question we asked, beliefs about social prescribing effectiveness, was measured with social prescribing is a good way to address my needs. Expressing support is I would participate in the social prescribing program. Beliefs about meaningfulness is social prescribing will connect people and communities. And next slide, please. Here, the answer is actually expressing support for social prescribing. And we see that this time the connection is not with social loneliness, it's actually with emotional loneliness. So we see that there are actually two segments here. There are people who experience social loneliness and there are people who experience emotional loneliness. And the way they arrive at well-being according to our science is different. And people who experience emotional loneliness, if they express support for social prescribing during the survey itself, that's more connected to well-being. So this key, expressing support to social prescribing, helps us unlock the ability to address the needs of a different segment of our clients. Next slide, please. So those are the key findings from the analysis that was done. So I'm just going to go through four main implications. I won't read the slides. You can go back and take a look at them after the recording. But what we learned is that primary and community care discussions may focus on social wellness. There are some innovations, and one of it that I came across in the literature is having trainees, health professionals, or social workers to lead wellness clinics in vulnerable population or housing areas. Next slide, please. And then we also, because of the numbers that we got, we were able to, which we didn't show you today, we were able to crunch some additional numbers called effect analysis. And we found that emotional loneliness is 2.3 times more detrimental than social loneliness. So that deeper a sense of loneliness, that feeling rejected or things like that, that probably warrants more attention from community connectors and also our healthcare professionals. So you can imagine, like, some of the clients that you receive, some of them might be a little bit more, I don't know, maybe you don't want to use the word difficult, but maybe might need a little bit more cajoling to say yes or to start attending some activities. Maybe they belong, maybe they are part of the emotional loneliness group. Of course, there are some overlaps between these two groups, and that's for the analysis. Next slide, please. So with all this, we know that but usually when problems present themselves, usually it's way past some of this loneliness issue. But if we can address loneliness in a more proactive way, we can solve problems before they upstream, before they become bigger problems. And in the past few years, loneliness has been shown to be very important, and it's increasing as we age. 1 in 4 seniors age 85 above felt lonely at least some of the time, and it is as bad or slightly worse than smoking up to 15 cigarettes a day. So social emotional loneliness is just as important. Next slide, please. So we talk about expressing support for social prescribing may improve well-being among people who report emotional loneliness. And one takeaway of that is we might want to start to look into something called motivational interviewing. Is essentially an evidence-based approach of a reflective listening and eliciting change talk. So basically, we want the person to come to a point of saying, "Yes, I want to explore changing." So, and that how we come to that point is through what's called reflective reasoning, and also asking questions in a way that share back with other people what we are hearing from them, and how that align or does not align with their goal. So we put the ownership back to them, so that the wanting to change comes from them. So there are some trainings that are available, and I imagine some of you are familiar with this, and perhaps more resources on this might be helpful. And of course, we will always love to help co-develop resources together. Next slide, please. And of course, our research today is very preliminary, so we only explore loneliness and well-being through 7 variables or factors. There are other variables maybe at play. Over 90% of the link, because we were able to calculate, remains unexplained. Some of the things that came up in our discussions based on also current literature is maybe we need to start thinking about positive self-beliefs, self-efficacy, resilience, trust, change readiness, provider motivational interviewing skills. So if any of this resonate with you, or if you have other ideas, please feel free to share with us. Next slide, please. So to summarize, 2 key takeaways. Primary community care, which all of you are part of, can promote health as adaptability, including social and emotional wellness. So that comes across very clearly. The second point, which is really new, tailored interventions and motivational interviewing may address older adults' emotional loneliness for better social prescribing enrollment. So we'll be happy to chat a little bit more about some of this if there are questions. And next slide, please. Of course, I don't do this work alone. Thank you so much to Dr. Kiwaka for leading this work, and also our funders and co-authors. There are some pretty big names here. It's a great privilege to be able to work with all of you. Next slide, please. Yeah, and so if you want to learn more about the specific recent analysis, you can take a look at the chat. I also see that Dr. Laura Kadwaki has dropped a link to the report, to the general report in the chat as well. And I will pause here, and I'll hand over to Dr. Adam Holman and Gloria.
Thank you, Daniel. And truly an honor to be with you all this morning, sorry, where the opportunity to make a case for group medical visits as a social prescribing pathway has been the reason for the invitation to join you. And I think I just want to be open about the feeling of talking about this with you all would feel a whole lot more applicable if we were all sitting in a circle in the same room. So as much as we can envision that the technology we have available brings that possibility about, I'd just like to offer that as an initial hope for thinking about how we engage in this discussion. And then to say it's a great honor to be having this opportunity to reflect on these topics, particularly around social well-being, with my colleague, friend, and mentor, Gloria Harding, the Indigenous Relations Manager for the Nanaimo Division of Family Practice. And Gloria, if you have the opportunity to turn your camera on, we can go through this together. And as Daniel said, this is, I think, clear as ever. We don't do this work alone, and in the same way, we don't do this life alone. So it's a real joy to be here in the Snuneymuxw, traditional ancestral unceded territories that have been stewarded by Coast Salish Snuneymuxw people since time immemorial, and an honor to be living, working, playing, and thinking on how to improve health and social care in this setting based on such wisdom. One guiding point here that has been meaningful over the last near decade has been this idea of the habits of an improvement science as brought into the traditional space, informing such organizations as Health Quality BC and the Annual Quality Forum, thanks to efforts of Don Berwick and others at the Institute for Healthcare Improvement, and picked up on by those at the Health Foundation in this same way, is that these, in the inner circle of co-production, I say this is really what I mean by sitting in a circle together, is we co-produce in every environment where we work with and for the benefit of improving health for all. This idea, now coined as the co-production of health and social care, really is our central aim, our North Star in guiding these efforts. But it takes thinking about how we communicate, how vital it is, both verbal, nonverbal, and the many languages, the 7,000 plus languages that are spoken presently, and the many thousands more that have been spoken since time immemorial on this globe. And then in the outer circle here, even though they might look like spike proteins out there, are habits we all, I'd say in many regards, collectively practice daily. Problem finding, being willing to sit comfortably with conflict, staying optimistic in the thick of difficulty, tolerating uncertainty, and maintaining that critical work of team playing, generating ideas, and critical thinking. I say are all relevant here and at the focal point of this effort to think on shared medical appointments, group medical visits as a vital part of a social prescribing pathway in primary care settings. This is further given a foundation around the efforts that the What Matters to Me movement first brought into being in Norway around 2014, now a international holiday, June 3rd, the What Matters to You Day, that I'd say is worth celebrating as well as learning more about. It is a vital question, but not only is it a vital question, it's a vital point of our work for thinking on how to both ask and then answer that question meaningfully everywhere all the time, as has been said, potentially worthy as an always event in healthcare. And with that, how the Connection Cure, written by Julia Hotz and exampled by many others, not only shifting from what matters, what's the matter with you, to what matters to you as the foundation, but thinking of how social prescribing really is about this power of reconnection, and that movement, nature, art, service, and importantly for today's discussion, belonging are vital pieces to that. We start with the end in mind in a way, and Andrea Wadman, a Simon Fraser gerontology master's student, who did a terrific thesis looking at participants of group medical visits here in Nanaimo, and brought about this journey map with really a single image to help focus on how our efforts around all teach, all learn at the core of this, summarized as education, is that we can learn, improve, and spread to the next how we measure our improvements. This is all in the basis of thinking how group medical visits offer that space of co-production. And there's much to learn of how to do it from the efforts of Ed Nofsinger and others at the Stanford Medical Group in the mid-90s in their work on shared medical visits and the volume related to that, as well as how many provinces, including Nova Scotia, are now bringing that work forward into how to normalize these efforts. And I'm adding links to the chat here to help that inform you all on where the literature is supporting group medical visits as a primary care and specialty related intervention and space redesign, spatial and clinical redesign. But we have to look a little further back in some regards. And my journey as an osteopathic physician was drawn into this approach to medical practice in the 20th and 21st century by the words of Andrew Taylor Still, founder of osteopathic medicine, who said that defined health should be the object of the doctor because anyone can find disease. And as a medical student, it raised the question for me, one that was not necessarily addressed in medical school, which is, what is health? What do we mean by that? And there's a definition that the World Health Organization gave in 1948 at its formation to say complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And that's been a great question for me ever since finishing medical school, entering family medicine residency, and then doing global health practice, and then a second residency in preventive medicine and public health, thinking, where is the discussion on social well-being? We have institutions and structures that focus greatly on physical and mental well-being, but where's the conversation emerging around social well-being? Which I would say has been a bit of a monkey in my back for many years, and perhaps it has for many of you. And I'd like to, with that, offer this, which has been helpful along the way, from the anthropologist, UBC anthropologist Wade Davis, from the Wayfinders Massey Lectures, Why Ancient Wisdom Matters in the Modern World. This definition of the central revelation of anthropology, I'd say, in quoting the first page of this Massey lecture, the idea that the social world in which we live does not exist in some absolute sense, but rather is simply one model of reality, the consequence of one set of intellectual and spiritual choices that our particular cultural lineage made, however successfully, many generations ago. And of course, that comes from the definition provided by Franz Boas, but there's been great critique of that as well, and thinking about the role of language and the role of many perspectives that have brought together ideas of social existence, belonging over many spaces and places and times. Gloria, any thoughts so far that you have to share? I'd welcome them.
Okay, sure. One thing I wanted to talk about is just to share a little story with you. I got involved with the social prescribing committee because so much of the work made sense to me around an Indigenous perspective of people gathering together and supporting one another. And we know that there's a very common theme with all Indigenous communities about how we take care of our elders. And I'm 65 years old. And one of the things that I do for my wellness is I work because I still can. And I have social connections. Coming out of COVID was very difficult, but I did work during the pandemic. So those things have kept me linked in the community. And I'm doing a program right now at UBC. So those things, keep my brain going, keep my health going, and my motivation. And I think especially because of social isolation during the pandemic, a lot of people got stuck in the idea of being at home, and then were also really afraid to go out because they might get sick. And if you're elderly and you have other health issues going on, you are at risk. And I know when I was working during the pandemic, we were losing in the community about two elders a week. There was two deaths per week. So there was a real high rate of morbidity because of COVID-19. So people were scared. And I don't know if that's ever entirely left the community. So when social prescribing came out, and I was invited to join the committee, I just thought, what valuable work this is, because we're bringing the community out, we're bringing people out of isolation, and we're walking through that transition with them. And we know that the elderly, don't transition well sometimes without that assistance. So I was really impressed with the work that was happening. I was impressed with the information that was being shared with all the partners that were at the table. And we've had some great events in Nanaimo. and mainly based out of the senior center, but we also have what we call link workers that are going out into the community, and pulling people out of the house basically and encouraging them to come down to the senior center or, get out in the community. And one of the things that really made me aware of how important this work is I thought, what do we as Indigenous people see as healing? And I want to show you a slide because this it captures what we see as healing and how it aligns with social prescribing. So I'm just looking for this slide to share. Give me one moment. And what I can say is that I really admire the work and the courage of the physicians to be able to, take that chance of well, it doesn't resonate with or align with formal medical Western medicine, but social prescribing definitely aligns with what people need in order to stay well. And I will just pull up this slide, and I'm hoping that you can see it. Should have been more prepared with this, folks. My apologies. There it is. Can you see the slide? Just let me know, Adam.
Not yet.
Not yet? Okay. Hmm. Okay. Well, I can speak to it because I don't want to take up more time digging around to try to get a slide on the screen here. What we focus on when we think of traditional healing practices is our sense of belonging and people gathering together. And in 1998, I was initiated in the big house in Musqueam. So I've been a member of that big house. So even though I'm not from that territory, I am, a member of that Coast Salish community. Musqueam's in Vancouver, for those of you who don't know, and it's a First Nations community. And the big house and the community getting together and taking care of their elders is really a significant part of the culture, and I think that's across Canada. And one thing that we talk about often is taking care of elders and making opportunities in for elders to come out and step out into the community. And what they've always done is had elders luncheons, elders support groups. They've held support groups for moms and babies, that kind of thing. And also, what's really important, I think, for social prescribing and everybody in general is the thing of people getting together, having some food together, and then also doing an activity together. And often you'll see like beading groups, blanketing groups, that kind of thing. So when I went over to the senior center where the social prescribing kitchen program is held and different things, that's what I seen people getting together and holding each other up and being there for one another. And it really, really impressed me when I saw how people genuinely care and that scared new person coming into the group was welcomed with open arms. And that means a lot. And we need to remember, and I'll finish by saying this. Many of our senior citizens, if not all of them, help build this country. We got to take care of them. And the way we do that through social prescribing is by being there for them, holding them up, bringing them out of the house, and making them feel like they still belong to the community. So I just want to thank you for listening. And again, my apologies about not being able to show that slide. It had some great pictures on it, but it covered the topics that I'm talking about. So before signing off, just want to say, looking behind me, this is the beautiful Nanaimo, and this is what we call the Collier Dam Trail. And I often see myself when I look at this slide just sort of going back into the forest. And and that's part of my social prescribing is being able to be in a place where I feel safe and comfortable, and then come out and then be with people and then bring people to the forest. So thank you. And I just want to raise my hands and say Hashkasiyam. Thank you.
Ashka CM, Gloria, thank you. Ashka. And feel free if you find that slide and can put it into the chat going forward, that would be lovely and helpful. So we can refer to that going forward. So I want to bring the words of Avitas Donabedian, who's in many regards one of the grandfathers of the quality improvement movement, a physician, public health physician, poet, and one who said these words, printed in the New England Journal of Medicine. Ultimately, the secret of all that we do in this quality work is love. You have to love your patient, you have to love your profession, you have to love your God. If you have a love, you can then work backward to monitor and improve the system. And I think this is true anytime we sit in circle. As Gloria's beautiful words make clear, we have to engage in that sense of trepidation when we gather. And I think this is one of the key components in this work of the value of social relationships are evident in much of the literature from the early days of Sir Michael Marmot and the Whitehall Commissions and all the literature supporting the World Health Organization Social Determinants of Health Commission, including some of the work of Julian Holt-Lundstad and colleagues. It said these relationships are key to health and health policy. And go figure, this is what humans have known since time immemorial. And now it's published for nearly a decade and a half, that the odds ratios for the statisticians or the epidemiologists in the crowd, the odds ratios for decreasing mortality are at least on par, if not outpace the traditional risk factors of smoke and alcohol, exercise, air pollution, BMI, and hypertension drug treatment for social relationships. So how do we get into that span of meaningfully not only asking what matters to you and connecting with those organizations and people and others who share those interests, but really see that it's the longitudinal relationship that matters. And this is much of the work that Kiffer and others through the Canadian Alliance of Social Connection and Health have brought together and attempted to make plain to the wider community how this looks in practice. A few ways by which I've seen this show up day to day is being a grandson of white settlers from Eastern Europe and Southern Europe to this continent. I have seen that how, as an immigrant and grandson of immigrants, this is clear in a reflection of place and concepts of place and how the concept of place informs care. On the left-hand side, you might recognize this island there. It's a beautiful shirt that was worn by a Newfoundlander in my panel. And I say it's a great depiction of what the Gander effect is in practice. Maybe some of you have seen, or many of you have seen, the musical Come From Away. And the Gander effect and what happened there on that day on 9/11, welcoming the thousands of those unexpected in that town, though they had prepared for that arrival, into their homes, into their celebratory spaces, into their mealtime and musical making gatherings, was life-saving. I'd say this is still relevant. And if we look on the right-hand side, this is a map from 2012, StatsCan and CDC Wonder, looking at life expectancy estimates in our region. And this inspired a great amount of thinking around what we see even in our region as far as longer life expectancy estimates at birth, which are the darker areas on this map. The 49th parallel creates a clear health divide here. But what is it uniquely around the interior and these Kootenays and the Central Coast near Bella Kula that is unique there for helping life expectancy and longevity be so available? And Kiffer and others and I have looked at extending this map and found some of these same patterns across the region continue. And so I think there's lots to learn about the role of social connectedness or absence thereof leading to this. And a cartoon here that helps describe that, at least what we see at the 49th parallel in this regard, that in perhaps we might pose the working definition of social well-being around having a lower cliff, being further away from the cliff, and greater propensity for sharing. And this is where the role of place around social connection and responding to the social determinants of health was made clear 2011 by the Hawaii State Department of Health, that a concept of place is vital for thinking of how do we put in motion meaningful clinical approaches that respond to the fundamental determinants of health and well-being. And you can see that they used a local familiar image of near the waterside Makai and up at the mountaintop Maoka for thinking about going upstream and using local language and cultural norms, as well as geographic and topological and space-place norms to think about this, where most of what we do in primary care addresses the downstream effects of chronic disease, where on the shore are the standard known risk factors, and across the river, access to healthcare. Going further up the waterfall, we see the many determinants of health, but at the top of the stream are political context and governance and social and economic conditions, Maoka, most upstream root causes. And at the same time, around 2011, I was introduced while at the London School of Hygiene and Tropical Medicine to the British Medical Association idea of what can doctors do about this, where they say predominantly non-medical action is required for making an impact upon the health and life expectancy of individuals and communities. Concurrent with that, at the same time, I learned about the work of Audrey Prost and others looking at participatory women's groups, and it changed my approach to care for good, because thinking about the reduced maternal and infant mortality from being a member of participatory women's groups in 5 low and middle income settings, Bangladesh, Nepal, and several other countries, where it was clear that groups discussing danger signs, raising community-wide support for maternal health, organizing transport for pregnant women, and contributing to emergency funds and transport and healthcare costs had a reduction in mortality. And go figure, it's what humans have known since time immemorial how to do in such organizing ways. So that coincided several months later with meeting this tremendous mentor, friend, and innovator in the realm of shared medical appointments, Byron Haney, Dr. Byron Haney, family physician in Ellensburg, Washington. I met just several months after returning from the diploma course in London. And what Byron was seeing was that the patients with diabetes in his group shared medical appointments were reversing their diabetes by participating in these regularly occurring groups, by building the connectedness that Gloria was describing, by learning each other's stories and traveling along each other's journeys, such that we sought funding for the Gold Humanism Foundation for looking at this from a research perspective. And that led to an article that I'll add here to the chat for everyone to read by Kim Wadsworth and others, as we began looking at how to bring medical students into the fold of learning from elder physicians how to lead such groups. And as you can see, the New York Times took an interest in this for an article they did in 2016, which was in the back of my mind for me, and being introduced to social prescribing upon my arrival to Nanaimo, being asked to help co-lead the efforts for a social prescribing program in Nanaimo. And I began thinking, we have a link worker model from the World Health Organization's how to implement social prescribing, as idealized here in this triptych, with link worker at the middle. But again, began thinking, who can be a link worker, as the report and many others from the National Academies of Social Prescribing talk about. And perhaps the link worker is as much a representation of a pathway, and that perhaps group medical visits, shared medical appointments, alongside link worker focused programs can be a pathway for helping connect meaningfully with the answer to the question of what matters to you, to community sector, the community sector and community organizations where that question can be answered. And I'll add this, for those who don't know, the implementation guide for social prescribing, where this comes from. But I'd like to say it was one of our family medicine residents who, when looking at this, took a moment to say, what's going on there around the link worker? Is that a halo? Or are those spike proteins? And I began thinking too, this is much like the Renaissance art, where in the middle is the Messiah, perhaps with Mary on one side and the saints on the other. And is it possible that when we think about the pathway of social prescribing more broadly, we might think about what is contemporary and relevant in various settings, unique to the language and culture and norms of a place, that link workers have an important role to provide, not only as individuals, but as in groups. And that's where the work around thinking about group medical visits, shared medical appointments comes into this, because perhaps even peers in the participation of such a group, where the trust that is built over time from accompanying each other in each other's journeys of health and illness, deepen a manner of belonging, of social well-being that allows that all teach, all learn rubric of improvement science, healthcare improvement, and habits of improver to exponentially grow a social prescribing pathway in many, many settings where there might not yet be link workers, or there might even be link workers who can help champion participation and build comfort and ease in participating in such groups. So coming back around to the work of Julia Hotz, who in the Wall Street Journal opinion piece late last autumn, essentially, this is not a panacea, that social prescribing is not a panacea, but simply helps, just like group medical visits, to reconnect us to each other. So I welcome your thoughts, questions, and reflections on our conversation here, thinking about how we are all in this effort of co-producing health and social care. And I'd say, please do feel free to stay in touch. Look forward to collaborating and conversing with you all going forward. And with that, pass it back over to Laura, Kiffer, and look forward to the discussion.
Thanks so much, Adam, Gloria, and Daniel. Your presentations, I think, really spoke to the need for us, our health systems, our communities, to redefine how we think about health and what we thought about health. One thing that stood out to me with both of your presentations was this idea of kind of co-production. And oftentimes in my experience, we talk about co-production in the context of designing programs or interventions. But I think both your presentations highlight that health itself is co-produced, whether it be through that dynamic interaction between patient and provider and comfort levels and motivational interviewing, or through the context of co-production in a group medical visit. And I think that's important, because we shouldn't conceptualize what we're doing as delivering health to clients, but working together to create health. And how your presentations, I think, each speak to expanding that circle of people providing care wider and wider. And so I think those are really important foundational ideas. So I wanted to, just with the time that we have left, I wanted to maybe invite each of you to reflect on, how do we increase that? Like, if you had like one or two key ideas of how can we increase the openness of our communities to engaging and participating in that wider circle of care, what would be your one or two kind of key points? And maybe we can just kind of go in the order that you spoke, Daniel, then maybe Gloria, then Adam. And yeah, thinking about those things, if you have something to say.
Yeah, that's a great question, Kifa. I think I have to think a little bit more about it. I think so much of research is done apart from community context, and also from the work of frontline workers. So I think if we could gather a little bit more about their thoughts and ideas, and that's very much in line with my approach to research, community-based participatory research. I think we would maybe together move the needle a little bit more. Yeah, I think that's my preliminary high-level answer, I guess.
Yeah, thanks. Yeah, community-based research certainly plays an important role there. Adam, do you have any, or Gloria, do you have any thoughts?
What I'm thinking about is, how do we weave social prescribing into the community? And it's about, attraction and definitely promotion as well. But also, I think about engagement. And, when you're hosting activities and doing things with patients, the important thing is to get the word out in your clinics that this service exists. And I think that again, posters and notices up on the memo board kind of thing in the clinic lobbies, that's a start. And then physicians being aware that this service exists and how to do the referral process. So there's that part. And then, you know, I know that there was talk about a creation of a newsletter going out of some sort just to update the community on what's going on with these kind of events. And I think that that would really, really help. And I know that we recently had a gathering, and there was a lot of people there in the community and a social prescribing day at VIU. And what a wonderful event and a great turnout. So those kind of things get the word out and just share with people, hey, guess what's available? And I know a lot of folks have said to me, well, my mother or my father, they stay at home alone a lot. And, you know, it'd be nice to get them out. You know, I'm worried about their health. I'm worried about them just being so isolated and their mental health. Like that's a big thing is mental health and the way it affects the body. And we know from an Indigenous perspective that holistic wellness, you know, for all community members is significantly important if we want to stay in good health. So, you know, that's what I think of. I think of engagement and community gatherings. Thank you.
Yeah, Gloria, I think bringing people together and like spreading through that networks is a great point. And so leverage what we're already doing and do it more. Adam, any kind of final concluding thoughts from you about widening the circle?
Thanks, Kipper. I think it's vital to think about the role of friendship and family. In this regard, I often say I was drawn into family medicine feeling that family is the medicine, but not everyone has immediate family close by. And so the role of neighborhoods and friends and those friend networks for being able to offer the kindly invitation that I think link worker often fills the role, especially when we're talking about disconnection or isolation and loneliness, that the invite, the simple invite of a trusted individual to a space and then going with them to the space, as we say in social prescribing, getting out of the signposting, but to have someone to go with and participate, make those introductions, all that happens so naturally in many, many settings. In some regards, I'd say as, you know, the cultures and communities that have plazas where they can gather, you know, this third space idea is so vital. And I think the role of partnering with cities, municipalities, and just thinking differently about the built environment, the physical environment for fostering third spaces where folks, anyone can gather and just simply be in the shade in the afternoon together under the midday heat and just sharing meals, sharing laughter, sharing conversation, and how that can be nurtured in any setting, as we've just known how to do as a species for millennia. So look forward to the conversation. Further questions, please feel free to reach out. I'll add my email here to the chat. And thanks everyone for being here today.
Yeah, thanks so much, Adam. And with that, thank you all of you for attending today. I think in all the presentations today, we identified that it's an intellectual battle, a cultural one, a systemic one, to really recenter health on communities and relationships. And so very grateful for the opportunity to help share that message. With the work backed up by the work of the United Way, BC, and with the Canadian Alliance for Social Connection and Health, I think together we can achieve these kind of great revisioning of our health and care systems. With that, thank you all for attending. Laura, do you have any final closing announcements before we let people go?
Yeah, so just as usual, we'll have the recording available for people to view afterwards, as well as the slides. And we also have Gloria's slide, which we can send out. And unfortunately, we didn't have time for audience questions, but the contact information, I'm sure Adam, Daniel, Gloria, if you're okay, we could share your contact information. And then if anybody does have a burning question, please feel free to get in contact with them. And I'm sure they'd be happy to share more information about their work. And so with that, as I know we're past 11 now, I'd just like to really thank our amazing presenters for joining us today and sharing their insights, and also Kiffer for moderating. And thank you everyone for joining as well. And I'd encourage you to sign up for our fourth and final webinar in June if you're interested, and we'll send out the link for that as well in the follow-up message so you can sign up. So thank you everyone, and I hope you all have a great day and also a wonderful weekend. Take care.
Thank you for your work in the community.